All right, let's continue with our supine examination procedures. The first one is the SLR, the mother of all nerve root tension signs. So what is the primary function of a straight leg raiser test? Well, the primary function is the assessment of a space-occupying mass in the path of a lower lumbar nerve root. Secondary is very diagnostically weak, and that would just be assessment of SI or lumbosacral involvement. Very weak, but um, SLR is 86% accurate for a disc lesion. However, keep this in mind, a normal straight leg raiser does not eliminate the possibility of a disc, because you could have a small disc or a really large canal, or you might even have IDD, internal disc disruption. So it's a different kind of disc, right? But we know from research that as the lower lumbar nerve roots move or traverse in and out of the IVF, they can move upwards of about a half an inch in and out. So as you're performing a straight leg raiser, like we see over here, these nerve roots are going to move about 12 millimeters or a half an inch, and they need to be able to do that freely. Well, studies on cadavers that did not have any herniated discs reveal that the pressure between the nerve root and the disc does not change until the leg is raised to about 30 degrees. So what we're saying is from 0 to 30 degrees, all that happens is the slack is taken out of the nerve until it finally bumps up against the disc. So the anterior aspect of the nerve root kind of effaces posterior aspect of the disc. All right, diagnostic value for this test is only L4 and L5. Those are your only diagnostic levels. The highest amount of pressure build from this test is L5S1. You get a 50% reduction in pressure at L4, L5, 10%, pretty much insignificant. You'd have to have a really large disc lesion in order for it to produce a straight leg raiser. In the supine position, we'd be doing more of a femoral nerve root test at that level. Let's go over this in greater detail. So here is our subject just kind of laying in a relaxed posture. And if you'll notice, the nerve root is slack, right? If we just look at it, it's just kind of hanging out, just really slack. Okay. All right. Now, from 0 to about 30 to 35 degrees, again, all that happens is the slack comes out of the nerve root. Okay, and that's what is being demonstrated over there. However, if there's already a space-occupying mass creating tension to this nerve root, then it's going to be provocative at a very early degree of leg flexion. Okay, and so that's really, the hot zone for a straight leg raiser is about 0 to 30 or 35 degrees. And if you have a positive one at that degree of flexion, you likely have a disc case. Okay, if it's non-provocative at 30 to 35 degrees, that does not mean the test is over. You can take this test up to about 60 to 70 degrees, somewhere in that range. And at that level of leg flexion or beyond that, there's no additional tension that's put on the nerve root. Okay, so it pretty much is over. If you're at 90 degrees and the patient says, well, I have some back pain, that's really an inconclusive test, because the test is really not for back pain anyway. It's really for determining if there's any nerve root tension. So it's an excellent test when properly interpreted. All right, so there's some enhancement maneuvers or sensitivity maneuvers that can be added to the straight leg raiser, and this would be getting back to tandem testing. Okay, so let's say you're at 60 to 70 degrees with a straight leg raiser, and there's no symptoms. Or it's obscure, or maybe the patient has obscure intermittent. It doesn't come in necessarily with acute sciatic symptoms. So you bring it up to 60 to 70 degrees, and then you add these tests one at a time. You add a Sicard's, you add a Braggart's, you medially rotate the hip, which we'll show you what that's all about shortly. You add a Lindner's, you add a Valsalva's, you add a Desjardins, and see if you can bring it out. All right. On the other hand, the sensitivity maneuvers is when you have a severe case of acute sciatica, okay, and you just want to verify that it is nerve root tension that's causing the pain. So you take it to the point of pain, and then you lower it to a degree where there's no pain, and then you can do Sicard's, Braggart's, medial hip, Lindner's, or Lessegs to see if it does exacerbate the pain, indicating nerve root involvement. This was an interesting test. It's kind of old, right? It was done in 1974 before we had advanced imaging, but there's a lot of value here. What they did is they had 50 cases with low back pain and sciatica that were going to surgery. So before surgery, they did a straight leg raiser on them, and they asked the patient, did this straight leg raiser cause back pain? Did this straight leg raiser cause low back pain and leg pain? Or did this straight leg raiser just cause leg pain alone? So they got the answers from the patients, and then they went in and they saw exactly who had a medial, who had a lateral, who had a subrasal disc. All right, so what they found in this study is with a subrasal disc, you had low back pain alone during straight leg raiser. All right. With a medial disc, you had low back and leg pain. And with a lateral disc, you had leg pain alone. So again, really good information in interpreting these straight leg raiser tests. And if you're doing a straight leg raiser on someone and they say leg pain alone, consider that they possibly have a lateral disc. And then, of course, you can look at the antalgia to verify that. All right, and so this is from spine surgery in 1994, and that's where the statistic comes for 86% accuracy rate. And, of course, that goes up if you have imaging to verify that. Sciatic nerve root variants. There's all of the 6 variants that we're aware of, and prior knowledge was that someone with a variant had a greater tendency to a piriformis syndrome and irritation of the sciatic nerve. And then this study came out. This study came out in 2018. There were no significant differences in the prevalence of piriformis syndrome, buttock pain, or sciatica between normal and variant sciatic nerve anatomy. So, for whatever that's worth, there's more information for your head. Braggart sign, you're well familiar with it. It's a sequelae to straight leg raiser to make sure that it is the nerve roots, not some tissues in the lower back activated by flexion that is causing the patient's pain. Well, leg raising sign, if you don't understand the mechanism, these slides clearly go over it, but with a medial disc, if you raise the opposite leg, it draws the cord over to that side and entraps the nerve root and increases pain. But with a lateral disc, it relieves pain, again, because it's pulling the whole cord over and that would relieve pain off of the lateral disc. So again, more really good information and interpretation of the straight leg raising tests. Cox's sign is a variant of a straight leg raiser. Dr. Cox calls it a grave sign, and it's a straight leg raiser positive from 0 to 15 degrees, where the patient, as you raise that leg, the patient lifts their whole pelvis off of the table, indicating to you, don't raise my leg any further. Unfortunately, these are typically indicative of a far lateral prolapse, and it's likely a surgical case. Here we have some tandem testing, as we had mentioned previously, and you can do tandem testing with Vectorus, of course with slumps, and you can do it with straight leg raiser. And here you see Dr. Cox adding Lindner's to the straight leg raiser. You can add as many tests as you want to it. You can add Desjardins, you can add medial hip rotation, you can add Sicard's. It's just, you can get creative with it. Tandem orthopedic testing. Medial hip rotation, this is the actual test. You bring the leg up to 60 degrees. Of course, if the patient can tolerate 60 degrees. But if at 60 degrees straight leg raiser is non-provocative, then you medially rotate the hip. So it's kind of, you rotate the toe in or medially, and that adds a 15% stretch to the sciatic nerve roots. So it's another enhancement test. Where did that come from? It came from this study that was done in 1979, and these are these little pieces of tape. Those are little centimeter rectangles, and those are kind of sewed into the sacral plexus. And you can see in this picture here, the subject's feet are both pointed straight up toward the ceiling. This one here, you can see the left one is toed in, or the hip would be medially rotated, and you can see we lost a centimeter here. All right, and that interpreted by the researchers indicated a 15% stretch on the sacral nerve roots. So that's another enhancement maneuver. Faber-Patrick's is the quintessential test for the iliofemoral joint. Extremely, extremely valuable test. And if you've never seen a positive one, typically what'll happen is when you try and put the patient into that position, they're already hesitating. And if you try and push down on the knee, like you see the doctor doing there, they will not allow you. Plus, you will feel a tremendous amount of resistance. And of course, it's indicative of some type of hip joint pathology, usually inflammatory degenerative joint disease. Bowstring sign is another, kind of variant off a straight leg raiser, and you basically take the straight leg raiser to the point where it's positive, lower it to where it's not positive, flex the leg, and put pressure into the popliteal fossa. And if that reproduces the patient's sciatic pain, it is considered irrefutable evidence of nerve root compression due to a disc. Gainsland, one of the quintessential tests for SI joint involvement, and of course it's the leg off the table that's being tested. Muscle girth, we don't do this all the time. If you're suspicious of a neurocompressive lesion that might lead to atrophy, certainly do it. Get a good tape measure and measure either 4 or 6 inches above and below the patella and make a record of it. It's good to have this just in case the patient said, "Doc, I think my calf is shrinking," and that way you have a standard to measure it against. Muscle strength for motor function, you can either use great toe extension, for an L5 nerve root, great toe flexion for S1, and or plantar flexion or dorsiflexion. Those are all there for your review. You're familiar with all of those. These are just all of your myotomes. So, the muscles related to each particular nerve root. Again, I know you're familiar with that. All right, then we turn the patient prone. Yeoman's is another excellent test for SI joint involvement, and just put some resistance, some pressure into the SI joint as you bring that joint into extension by extending the leg. Eli's sign is kind of a femoral nerve root stretch sign. It's also shows if the patient has really tight hip flexors. Farfan's torsion test. All right, this is a new one to you. Quite an easy test to perform and indicative of a torsion-based injury if positive, and a really good test to perform if you're going to do HVLA side posture manipulation on a patient with pain. And this is just an example of it being done. And you always do it on both sides. So here the examiner is stabilizing the thoracolumbar area and then grabbing the ASIS on the left side, and then he's just going to try and rotate the lumbar spine. And if positive, it could be indicative of anything going on here or any other tissue that might be injured from excessive torsion. Henceforth, it would behoove us not to do more torsion until that has healed or this test is negative. Prone knee bending, the main thing I use this for is spinal stenosis. And we know that patients with spinal stenosis do not like extension. And when you bring both heels to the buttocks, it extends, it puts the lumbar spine into extension. And if you keep them in that posture for about 20 to 30 seconds, it might reproduce their leg pain. It also is used to assess the upper lumbar nerve roots or femoral nerve inflammation. All right, gluteal skyline sign we went over. We mentioned that it's actually a motor test to test the L5 and S1 nerve roots. You basically have the patient contract their buttocks. If one is flaccid, then you have motor dysfunction to the inferior gluteal nerve and flaccidity of the glute on that side. Sensory dermatome evaluation. You can use these pizza cutters if you prefer. I use my fingernails. It doesn't matter what you use as long as you use the same thing every time, and my fingernails are a lot cheaper than disposable pizza cutters. We've gone over this in terms of the characteristics of dermatome maps, and we have expressed to you that the accepted dermatome distributions is S1 little toe, L5 big toe. This is an old chiropractic examination form. This is about the extent of my exam when I got out of chiropractic college back when the Earth's crust was still cooling, and it was really all that I needed. I would check for edema, right? I would palpate, or I might mark a little edema there. Maybe T5 was involved, maybe L5 was involved. I would check for tenderness. If the spinous was tender, I would check it in the middle. If it was tender to the right, I would check it to the right. I would check for paravertebral muscle spasm. Again, either central, right, or left, and then I would check for fixation and write down if I felt there was fixation on the right or on the left, anywhere, so on and so forth. So we've come a long way, baby. All right, and I believe that does complete our lumbar spine exam. This is an excellent exam. I would suggest that you bring it with you into practice. Learn to do it properly. It only takes about 10 minutes or so. Once you have the routine down, and it will give you all the information necessary to do a comprehensive orthopedic, neurologic, and chiropractic evaluation and get you to an accurate diagnosis, which will help in successfully treating your patient.